horses, there's a freaking zebra in the herd. And that's when you just got to go back and reassess or change your treatment or change your thoughts. How's the pace been? Is this about right or too fast?
Yeah,
It's good. These are going to mostly be scenarios, the rest of this. Okay, this is a real story, or I'm sorry, real patient. This happened in the Los Angeles district in Santa Fe County. This lady is well known to EMS. She's been nasally intubated 12 times by us. The person who's the best nasal intubator and nasal intubation trainer that I've ever seen is Rob Laprice, the guy who's now head of the 7/8 Albuquerque Fire. And this is Rob's call. This gal lives about 5 minutes from the ambulance response, and they're about 25 minutes from St. V's. She's very well known to EMS, and something that she just decided to do, she took a little whiteboard about this big and attached it to her fridge, and she would make hash marks for how many nebs she had taken before she called us. And we always said, you know, call us whenever, but she always felt bad because she's well known. So has anybody ever nasally intubated a patient? Okay. And has anybody intubated an asthma patient? So that's a really bad sign for an asthma patient because it's kind of once intubated, you're going to keep getting intubated, and your recovery time typically doubles with each intubation if it's asthma or COPD. So this person has been nasally intubated 12 times. As I've been talking, you've probably been looking at these slides. So sick, not sick?
Sick.
Yeah, she's sick, right? Now, is she going to lay down and let you listen to breath sounds and do a neb and all that? She's sitting bolt upright in the kitchen chair, and she can't breathe. And she's got that expiratory trapping, which is part of what he was just talking about a minute ago. She's a little hypertensive, and she's tachy because she can't breathe. She's sick. Now, she's administered 15 hits of albuterol before you were there. I want you to study the waveform, and I want you to look at it in two different mindsets. I want you to first look at 2 and 4, so this one and this one. Don't look at these three little guys. Look at 2 and 4. So if you march to the left 2 and 4, that's where you got your end tidal of 52. Got it? If you look just at the waveform 2 and 4, the appearance is shark fin. 100% of the time that you see a shark fin appearance, it's a result of bronchoconstriction. You don't know from looking at it if that's because of asthma or COPD. But in this case, she's 32 years old and took 15 hits of albuterol. Is it asthma or COPD? Asthma. Now, that is a classic shark fin at 2 and 4. Now look at 1, 3, and 5. So boom, boom, boom. What's different about 1, 3, 5 from 2 and 4?
Looks like how it was with shallow breath.
Speak up.
Looks like how it was with shallow breath.
Like it was with shallow breaths, really crappy plateau. Any other descriptions?
Less CO2.
It is less CO2. What's happening to the patient for that to happen?
Is she trying to create PEEP?
Very good. She's creating her own PEEP, or, and this is what it's going to sound like, and if you ever hear this with an asthma patient, you'll never forget it. They breathe like this. They're creating their own PEEP, and that grunt is trying to force that CO2 out because she's gas trapping. It's a super, super scary sound when you hear it. It just sounds like grunt breathing because that's what it is. That's a very, very bad sign. Very bad. So she's grunt breathing. What's her end tidal? 52. She's sitting upright in the chair with the baby watching TV like 10 feet away. They get behind her. Anybody ever bagged a conscious patient who's tachypnic? It's tough. Do they lay down flat? No. You got to get behind them. You do that coach thing. You teach them to trust you. And then you start counting, and they're doing all that. Rob decides to go straight to epi. He gives epi 0.5 in each arm. I said, why did you do that? He goes, I have no idea. I've never done that before. She just looked sick as shit, so I did 0.5 times 2. Right. Okay, continue. While she's in the chair with no lube, and they don't have an IV yet for drugs, and they weren't carrying Versed back then, he says her name and says, "I'm going to nasally intubate you, hold still." He's got her head, she's sitting upright bolt. He puts the tube in, tells Jim, get everything out, get all the equipment out, and as he's trying to pass the tube with no lube, no nothing, she goes limp. He passes the tube. He decides to push the tube in anyway. Now, were you taught that apnea is a contraindication for nasal intubation? Yeah, we teach that. It's not absolute. In this scenario, with right where they are, trying it was good. The reason you're taught it's a contraindication is because the way that you confirm that it's in is they suck the tube and they start breathing. You can hear the breathing. She's dead, but he's very, very good at this, so he tried it. His first breath, no stethoscope, he sees this. Does he need to listen to breath sounds? She's still even limp sitting upright. He knows his tube's in the wrong hole. He pulls the tube, lays her on the ground. This time he orally intubates her, gets her on the first attempt. Auscultation reveals no breath sounds. The belly has no belly sounds. Minimal chest rise. Positive misting and condensation in the tube, but we know we can be tricked by that. We used to do this, we don't do this anymore. Something that we did, but we know you can be tricked. Auscultation doesn't help. The pulse ox never worked. She's like ventilating a brick. Anybody ever ventilated and you hear this, and it's not that your airways is not open. That's what she's making, is that crappy sound. So he's not sure where his ET tube is. Now, he hooks up in tidal. He sees this. Now are we sure that the ET tube is in the trachea?
Yes.
We're 100% sure of that. But we've got two major changes. The waveform is different, and the number is different. What should that number have been? What would you have hoped it would have been? What was it 30 seconds ago?
52.
52. It dropped 30 points in less than a minute. That's a terrible sign. They coded her for an hour. Her 13th nasal intubation was her last intubation. Dead stayed dead. On a witnessed cardiac arrest. He was super aggressive on the airway, super aggressive on the epi. Now, why is this waveform a little different? It still kind of looks shark finny, but it looks different than those others. Why is that? Two reasons. One, she's getting positive pressure ventilation. Two, is you're starting to see a little plateau because that epi's starting to work that's in her body. And they gave her buttloads of epi IV and dead stayed dead. So the zebra, or the red flag here for this call, was great care, but a number going from 52 to 22 in less than 60 seconds, her body's probably done. At the cellular level, she's checked out and dead stayed dead. Again, no bad care, I would argue really, really good care. But that's a call that should have not made sense to you when you saw the number went from 52 to 22. That should have been a flag. Okay, this is a real call. This happened to me, and it happened about 18 months ago. So I'm working in Hamas, and now Medic 31 has to do this. Who works on Medic 31? Oh no, I'm not talking to Sandoval. Sorry, we're at Rio. We used to have to do all the ALS intercepts to Cuba, and they have train wreck patients. And Cuba would always get pissed if we would jump the call before we were dispatched. And we would do it because we have a 45-minute response time. And we'd gotten in trouble for doing that. And so Cuba gets dispatched to a head-on MVA with ejection, 1 fatality, and 5 viable patients. This is about 18 months ago. They don't call us. The dispatcher screws up. Calls Sandoval. Sandoval sent a rig, Rio sent a rig. I think Rio sent 2 rigs because Sandoval was kind of out. And so people are starting to send rigs, and they haven't paged us. And then finally we got on the radio, 2538 Sandoval, we are available, we are ALS. 2538 respond. Now, Chelsea White's version of this just to give you an idea of what a big cluster this was, he's in his UNM consortium truck and he's leaving grants. And he's code 1. And he's listening to this cluster happening. And at that point, he was the medical director for all of Sandoval. That's now Jenna, his wife. His version of this is I was listening to this cluster, and I was saying, good God, they can't, and no helicopters available, everybody's screaming, everybody from Cuba screaming on the radio. And he says, I went code 1 from Grants all the way to the Big I. And then I finally heard 2538 going around. And he was medical director for us as well. He gets on the radio, I don't know his MD number, let's just call it 5. MD5 Sandoval, I'm available. I do have ALS equipment, would you like me to start that way? Stand by. And so I just got on the radio and said, yes, start that way. Because I knew that we were the first, but they've got all these sick people. And either the Rio rig or the Sandoval rig, I don't remember which, breaks down on the side of the road. So now there's just 2 of us. Was it you guys? I don't remember.
Sounds like it.
So I'm going to get this first patient, that's all the patients are being transported quickly through BLS, and I'm going to get this unconscious patient seizing and an active trismus. What causes trismus? Thank you for not saying head injury. What causes trismus is number 1, hypoxia. Number 2 is mandibular fractures. Yes, it happens with head injuries, but it happens typically because they're hypoxic, which is what you said. So what all can a paramedic do for somebody who's seizing an trismus?
Just back a little bit.
Bag them and maybe give some Versed. What do they really need? They need to be paralyzed. They need to be knocked down and so get in there and get aggressive with the airway. So I'm thinking, okay, we're going to be first. We do the intercept at night. It's at night, of course, on the side of the road. Most dangerous road. We're doing it, moving this guy who's wiggling all over the place. I BLS his airway. I put in bilateral nose hoses. By the way, if a patient will take 1 NPA, put 2 in. Just a good gold standard. You try breathing through 1 NPA. I just always put 2 in everybody. So I put bilateral NPAs in. I don't have a line yet, so I give him Versed IM just to stop the seizure. And then it dawns on me, I, the highest trained provider responding, I don't have the tools I need. I need the physician who's got RSI drugs. And I really debated, like, what a shit move to do to the other 2 BLS rigs. I'm like, this is my patient, and the best thing for him is to be paralyzed. So I start en route. I ask for an intercept. About 15 miles down the road, Chelsea pulls over. He's running hot at that point, and he jumps in the back. So I said, I'm getting the tube, and he says, you have no idea how long it's been since I've started 2 large bore IVs in a moving rig. And I'm like, knock yourself out. So he's doing the lines. I don't know if they're 14s or 16. He got both lines bilaterally. I get everything out for intubation and failed intubation, which for us in Hamas is the King Airway. Have it out. I have a King Vision out. I'm going to use the bougie. I have a stylet. I have the suction unit out and turned on by the head. You guys probably know that trick. Because you don't have special skills, Chelsea has to push the drugs. So, okay, we're ready, push the drugs. So he goes to push the drugs. I go to intubate. I can't remember if this next slide is going to say it or not. So let me just tell you, it was hard to visualize. I hadn't tried to pass the tube, but there's blood everywhere. I'm like, I can't see. And all of a sudden I'm looking in here, I can feel movement. And I go, I don't need crickway there. I don't need crickway pressure. And I look up and he's betadine the neck, getting ready to crike him. He's like, you have about 10 more seconds and I'm going to crike. I'm like, holy crap, got a physician, we're pretty aggressive. So, oh yeah, here it is. So I see the cords, I use a bougie, I pass it, I feel really good about it, did this in front of my medical director. Both of us confirmed breath sounds. I already had end-tidal CO2 hooked up. The chest is rising and falling. I'm using the exact same ventilator that you guys use, the Parapack Nupack, and it's a great vent. It's like calm. I'm in the airway chair. He's in the on the side, and it's already time to change bags of fluid. So he's like, "Hey, let's change the fluid." I'm like, "You're there." So he's changing the bags of fluid. I don't even remember what I was doing, but I was looking at the patient, and all of a sudden, and it was just the way he said it. He goes, "Hey, what's going on?" I go, "What does that mean?" He goes, "Look." it's not quite, okay, I forgot some stuff. So we're giving fluid, I forgot about this, sedation wears off, we give him more Versed, knock him down. Sucks. The medical director of your service is sitting on the bench seat and he goes, look, and the waveform is doing this. Now, pro tip, if you're using the ventilator and you want to confirm a tube, especially in a moving rig, never leave them on the vent. Because the vent does gas over time, it's way, way too hard to hear. Even in a house, I never do that. You'll see in the OR, they go to a BVM when they do it. So I immediately switched to a BVM. I'm like, Chelsea, I think I'm good. I hear it, I'm like, I'm good. And then I look over, there's my waveform with the Great Plateau, and I'm like, Chelsea, you listen. He's like, huh, you're good. Any guesses yet?
Vent went out?
The vent. So I hook him back up to the vent, and I get this. The sound was great. Watch the waveform. All of a sudden it disappears. And Chelsea says, I think it's the vent. I said, that's the best vent in the world, used it for 30 years. He goes, what are you gonna do? And I go, I don't know, I guess we're gonna bag him. So I put the BVM back up, and tidal CO2 comes back up. I'm like, what the hell? So, patients, the tube is good. I asked Chelsea to start ventilating, and I look, and that great vent that's out there is powered by what?
Oxygen.
Oxygen. My main O2 tank was dead. Hook them up to the vent to the D cylinder, perfect. Now, the LifePak 15 apnea alarm never went off, which told me we didn't screw up for 30 seconds. But if he wouldn't have been sitting there, I'm confident I would have missed that. It would have just suddenly been going off, and I would have probably, I better have figured it out. But in 30 years, that had never, ever happened to me, and it happened to me in front of a very respected doc who teaches this stuff. So I added it to the slide. 100% our fault, my fault, not his, for not checking the rig. I'm sure you guys check the rig every day for oxygen PSI levels. So here's a dislodgement. So you see, so look at the left and then the right. So there's a waveform. That's dislodgement. This is the tube is dislodged and it's in the hypopharynx. So there's 2 times that you're at risk for that. 1 is nasal intubation, and 2 is crikes. I come from the era before we had supraglottics. We did a lot of crikes. I've done 13 crikes. We thought we were really good at it. We did crike labs and pig labs. And we had RSI for Santa Fe County, and we had a very, very good medic who stopped practicing EMS when what I'm about to tell you happened, and he went on to become a state police officer. And he just retired 2 months ago after 22 years. So this is a very good medic. La Bajada Hill, southbound, motorcycle goes off, and he's critical, and I think he was even in Trismus. And he tries to intubate him, he can't, decides to crike him. So he crikes some guy, all by himself, starts towards the hospital, asks for help. Engine company jumps in on the side of the rig, and they take him in to St. Bees. The guy codes on the way in. It's a trauma code, but now the rig's a crime scene, so they're not gonna pull over, they're gonna go dump this dead guy at St. Bees. So they bring him in, and he's criked, and he's got lines, and the doc goes to listen for breath sounds, and can't hear breath sounds. And he opens up the mouth, and the mouth is full of plastic. There's a wrapped up ET tube in his mouth. And the doc goes, we have a problem. We couldn't believe that the medic made this mistake, because he's so good. And so we were trying to figure out how to recreate it in a QA environment. So we took that respirator tubing, it's like the little corrugated rib tubing, you guys know what I'm talking about? We took that tubing and we sprayed it with silicone spray and WD-40. And we brought the medic in and we said, here's a trachea, show us how you did the crike. And he's like, I did a crike. Well, did you do vertical or horizontal? Because I did both, because vertical didn't work. Vertical is usually less dangerous. He does vertical, didn't work, he went horizontal. What size tube did you use? I used a 5 cuffed. I go, we don't carry 5 cuffed, we carry 6, you should know that. He goes, no you don't, you idiot. Somebody ordered 5 cuffed, and that's what I used. So I'm like, Okay, I do the ordering, that sucks. And I didn't even know they made a 5 cuffed, but that's what he grabbed. He looked for the smallest cuffed tube, which is what we teach paramedics. So we have him cry, we have him do it repeatedly. Let's just pretend like this whole thing is the tube. And so,
You want an airway head?
huh?
You want an airway
No,
head?
no. Do you have an ET tube?
I'll look.
Because this is worth showing you guys. I was teaching this exact class at the Rio Doso paramedic refresher, and a gal starts crying. And when I said, I didn't say the guy's name, but I said he killed this patient. The gal starts bawling. I take a break. She goes, I've done this, did this exact thing, and I never knew how it happened until just now. So what happened? Now who can I crank just real quick? So this tube wants to go, this is how they look. And he's obviously gonna go this way. This tube wants to go south, right? That's why they're curved like that. It's got this tip that even is supposed to help with that. But it's a 5.0 tube and it's hotter than shit out during the day. This tube somehow gets like this. And he goes in and he hits that cartilage ring, and the tube went like this, and he can't see. And so when he thought he was going down, he was doing this. That wasn't the sin. The sin is that he didn't catch it. It's like there's no sin in putting the tube in the wrong hole, as long as you figure it out quick. So I teach everybody, paramedics, if you nasally intubate, and paramedics, if you cry, always, always, always open their mouth and see if there's plastic. It happens a lot of times with nasal intubations. They'll just end up in here. In which case you just pull it back out, position their head, do it again. But that call messed that medic up enough that he quit over it and went into law enforcement, pretty bitter and pretty PTSD. When I worked at Albuquerque Ambulance, when we were all cranking everybody, I did not bring this to them. I was taught this. Every Albuquerque ambulance guy, we took a 6.0 tube, still in the deal, and we taped them like this, and we had them in our flight pants. And one of the reasons was they wanted that tube to stay like that when you went out to crike it, because it turns out somebody at AS had done the same thing. I did not know that until decades later. I just thought we were doing it because it was cool and you kept the scalpel here and whatever. But for years, every AS person carried a 6.0 cuff like that, still in the thing. So, learn from our mistakes. This slide, this is a LifePak 15 tape. So obviously there's artifact on channel A and channel B. Look how clean C is. And C is the CO2. If you're seeing artifact, that's not because you're seeing artifact. That's because of patient movement, chest wall problems, or the patient's talking. There is no way a doc can say, you put the tube in the esophagus if you can show that piece of paper. You're like, no, it happened between the ER doors and that bed or whatever, but that tube is good. Okay, Gomer and Parapup. Parapup, what program did you go through?
Oh, UNM.
Were you taught that you might have to intubate a drug overdose?
I mean, we didn't go over exact scenarios,
No?
but
Did they teach you how to intubate a drunk?
No.
Oh my God.
Not particularly.
Did they
no.
teach you how to intubate a DKA? Oh
not
shit, you're getting
particularly.
worse. Did they teach you how to intubate a seizure patient?
Not particularly.
No. Did they teach you how to intubate strokes?
No.
God, you suck. Head traumas, neuromusculars?
Probably head trauma. Yeah.
Gomer, have you intubated every one of these patients?
Negative.
Which ones have you not?
Let's see, drug overdose. Actually, I don't think any of them.
You haven't intubated any of these? Wow. So usually when we do this, everybody says what you said, and I'm not making fun of you. But the older medics say, I've intubated every one of these patients.
Really?
And then the scenario is, well, does he suck and that guy's an expert? And the answer is no. The only difference is experience. And he's made, I'm not making fun of you, an older medic has made the mistake of not intubating a drunk who gets intubated upon arrival, and you feel stupid, or you've intubated a drunk who's leaving AMA before you've even written your chart and you feel stupid. In other words, he's got 20 years of experience and he's got 6 months. Wouldn't it be cool if the device could predict and tell you which patients to intubate and not intubate? And it turns out you can do this in about 3 minutes. And near the end, if I have time, I'll tell you about the predictive software thing. So dead people. In the beginning, we said that end-tidal CO2, we weren't sure if it worked in shock states, ICP states, and on dead people. Now we know that's one of the best places to use it. So when you're dead, boom, you're dead. Every minute that you're dead, end-tidal CO2 goes down. Your chances of survival are generally 10 points per minute. That's why at 10 minutes, most people's dead stays dead. Then when you do CPR, end-tidal CO2 comes up a little bit. Anybody in here a CPR instructor? Oh, here we go, Batman. According to the American Heart Association, if you did perfect CPR, what percentage is that as effective as the heart?
Less than 20. Less than 20.
The answer is a third. So if you do perfect CPR, and perfect CPR is a third, what should a normal acceptable end-tidal CO2 be in a cardiac arrest? A third of 35 to 45, right? So a freshly dead person, a fresh kill, 15 to 25 would be kind of normal. If it's lower than that, pre-existing condition or downtime. Turns out, several minutes before you get a return of spontaneous circulation, you get a spike of end-tidal CO2. Has everybody seen this or know about this? This is just cool as hell if you didn't know about it or see it. Then after you've been coding them for a little bit, it starts to come down and starts to get to what their baseline is. We knew since 1994, there's that third number that I was telling you about. We knew since 1994 that people in arrest don't produce end-tidal unless they have good CPR. But if you have normal blood volume and good CPR, your end-tidal will be about a third of the level. And again, 1994. So anybody who says you can't predict end-tidal CO2, you can't predict ROSC, which is a code save, return of spontaneous circulation, that you can't predict ROSC with capnography, doesn't understand capnography. We were teaching, I forgot the county. We were teaching for a county fire department in Washington, and we were teaching an ACLS refresher, but we had added capnography. And this is right when vasopressin and what was the other drug when vasopressin came in? Vaso and some other drug that AHA said saves lives, so we were focused on that. And we had just started this class, and we were teaching, they didn't know anything about capnography, so we were teaching it as a tube checker so far. We hadn't gotten to this slide. And we broke for lunch. We were at a station, and they got a code at a non-assisted loading facility. No battalion chief in the house. So the NG captain's in charge and in the class, and Troy and I said, hey, can we go on the code with you? He's like, that's not allowed. We're like, I know, but can we go on the code with you? He's like, yeah, get in the engine. So we get in the engine, a medic and an engine respond. So there's 3 and 2 and me and Troy. So there was 7 of us on this call. And I'm sure you got this somewhere in Rio Rancho. On a non-assisted retirement home, are those people typically helpful with resuscitation? Yeah, what are they typically doing? I'm gonna Xerox the chart, go into room 6 or whatever. So she says that. We go into the patient's room, patient's still in the bed, in arrest. There's nobody in there. So the captain's like, stop, don't do anything. He yells, DNR? Nope, not a DNR. So we put her on the floor. We start working the code. Somebody intubates her. We use capnography. I don't remember the number, 20, whatever the number was. And so they're pushing whatever the drug of the week was. And we're squirting around and trying to figure it out, and they're shocking her a few times. And it's literally just the 7 of us and this code in the room. And Troy and I are both watching the monitors right there, and we both see it. And the end-tidal CO2 goes from 20 to 40. And we know, and the rhythm is still asystole. We know what's about to happen. So Troy, being a smartass, goes, all right, everybody stand by. Shazam, check a pulse. And pulses, and the crew's like, holy hell, check a blood pressure, 150 over 80 or whatever. We know that this happens. It happens 30 seconds to 3 minutes before a rhythm change, a blood pressure, or a heart rate change. It's cool. It happens, I won't say 100% of the time, probably 89% of the time, but it happens very quickly, and then they get pulses back and you start doing it. And we don't typically in EMS, we stop staring at the monitor. In fact, we used to teach, don't watch MTV, watch the monitor, not the machine. So pay attention to it. And we know that, so the first study that was out said 100% of the patients who have an end-tidal CO2 less than 20 and get rhythm appropriate ACLS and ventilation and compression, 100% of them at 20 minutes of ALS, dead stays dead. Now we know 10 and 10. So what does that mean? We know that if you get on scene and their end-tidal CO2 is 10 or less, and you do rhythm appropriate ACLS, and 10 minutes later they're still at 10 or less, 100% of those people dead stays dead. That's how we call codes in HAMAS, and we don't do MSEP consult for that. Talk to Dr. Brody about whether or not he does. I haven't called for a code thing in, I don't know, 10 years. We just do it. Again, 1995, so almost 30 years ago. 30 years ago, yeah. We knew that you would get this funky rhythm change before you see blood pressures or pulses. We were told in the beginning that it didn't work as well with shock states. We knew 24 years ago that it does work. There's also a neat connection to compensatory and decompensatory shock and fluids and pressors. So let's do a gunshot wound to the belly, and obviously category 1, and he's tachycardic and hypotensive. Like, let's make his heart rate 150 and his blood pressure 70. What's your treatment going to be? And he has an airway.
Well, treat for shock, so warmth, quick on scene time, or quick transport time.
Yep, spatula,
oxygen.
dump him in the truck,
Yeah,
start
oxygen.
flying.
Since it's in the.
Why are you giving oxygen?
Just we're giving oxygen just because they're actively bleeding, so we gotta try to get good perfusion, and he's decompensating, so, and shock is just inadequate tissue perfusion, so we gotta get oxygen on board.
So what he said is all 100% correct. And even though they have no respiratory distress, you're giving high flow O2 because if he's actively bleeding, he has less red blood cells available in the system. I don't care what the pulse ox says. If it says 97, he still gets a non-rebreather. UNM will get that. Some of the other hospitals won't. We don't understand that. But yeah, so high flow O2s, what else?
We're gonna keep them warm. We're gonna put most likely an occlusive since it's on the torso.
Sure.
We can go ahead. We're gonna be monitoring our blood pressure. We're gonna get bilateral. Well, we could try to get bilateral lines.
You do, because you're a stud. You get 14s.
And we're gonna
in the neck.
We're gonna be running some fluids.
How much?
Just enough to trying to titrate to get a good like systolic, preferably over 90.
Rampart, squat 51, his blood pressure was 70. How much fluid are you going to give this guy?
All of it. I'll start off with 1,000 cc's.
Everybody agree with him? Anybody
Too much.
want to be more
Too
aggressive?
much.
Too much.
500, reassess.
Any of you guys had PHTLS? 20 cc's per kilo, reassess. 20 cc's per kilo, reassess. How much do you think I weigh in kilos? I weigh 120 kilos. How much fluid is that for me?
It's about 250.
It's over 2 bags. It's a lot of fluid. Now, there's a con to that, and I'm going to talk about that in just a second. But whether you gave 1,000 or 2,000, you did not say anything about capnography. This patient deserves capnography. Why?
Well, we're able to kind of see. Whenever I think capno, I kind of just think kind of as basic new medic student, like kind of the Krebs cycle. So we're not.
Geez, you're deep into that.
Yeah, we're not.
All the older medics like Krebs cycle. Shit.
Where
You probably had the
they're
thick
not
principle
getting. They're
memorized
most
still.
likely not going to be getting their oxygen at the tissue, especially if they're decompensating. So if they're not getting oxygen in the tissue, that means they're not producing. They're not going to be producing as much CO2. So I would believe that they would be alkalotic. I would believe. Or their SpO2 would be, end tidal would be high.
So let me help you, because you way overthought that shit. So this he's tachycardic and he's hypotensive. He's in a shock state. He's in a hypovolemic state. If he's in a hypovolemic state and his red blood cells are going down, his end tidal CO2 is not going to do this. His end tidal CO2 is going to follow the shock state and get lower. So then I was kind of setting you up. If you're doing fluid resuscitation, pay big attention to capno. So let me give you the scenario. Same exact patient, and his initial end tidal CO2 was 32. No respiratory anything. You're using a nasal cannula. You do 500 liters or 2 liters. Your next capnography is 40. You know for sure you're heading in the right direction, and you should probably even TKO your lines. Same scenario, you went from 32 to 24, he's about to die. He needs all his fluids wide open and more fluids. What's the risk of wide open fluids, especially with your transport times?
Fluid overload.
What'd you say?
Fluid overload.
And with fluid overload, what happens? Like, be more specific.
Well, your layman's terms, you're diluting the
Yeah,
blood. So
yeah,
you're
you're
not getting.
so you're making
Kool-Aid.
the red blood cells like Kool-Aid, and all that sucks, but that's all we got, and unless you call it a helo that's got blood products. So where I was trying to lead you is make your decisions about when to TKO, when to TKO or to give more fluids based on your capnography number. PHTLS and ATLS, the 10 cc's per kilo or the 20 cc's per kilo, is very controversial because of the fluid, the Kool-Aid thing. There was a very respected trauma surgeon who is no longer with us named Rick Clevenger. Before that, it was a doc named Chip Demarest, and both of them, I said, well, what's the magic number? And don't say 90 over 60, because that's all the bullshit that all the textbooks say. Is resuscitate them to 90. Keep their diastolic above 60. It's like, just give me something that's better than that. And both of them said the same thing. They said, if the blood pressure and heart rate are shitty, make it a little better. Not a lot better, just a little better. Now, why do they say make it just a little better, especially for knife and gun club, for shootings and stabbings, a single GSW or a single stab wound? Why do they say just a little bit better? Let me give you a hint. If you had a police officer shot, got him to the side of the vest, and he starts with 90 over 60, and he gets to, let's just say, 70 over 50, and you get his pressure up to 80 over 50. That's a good example. This is a really good example. Your protocol, and probably your training, says give more fluid to get at least to 90. What's the risk of giving more fluid? And it's not Kool-Aid, and it's not fluid overload.
Clot busting.
What?
Clot busting.
Clot busting. So especially for a single defect, so a single shooting, a single stabbing, the body's response is to immediately activate the clotting cascade and to send everything to try to clot. And so that clotting and lysing is happening, especially for isolated shootings or stabbings. So let's just say that is able to happen in an environment where the blood pressure is 70. You get the blood pressure to 80 or 90, and it busts that clot, and they've lost all their clotting factors. So that's the real controversy about fluid. Go ahead.
So on that scenario, can you base your treatment on MAP and trying to get their blood pressure just above MAP so there wasn't any, like, we're more worried about perfusion too.
So
Kidneys and
you're thinking perfect. I would use MAP, which not everybody understands, but you obviously do. I would use MAP and capnography together.
okay.
Where the flight programs do that, they use that decision for blood products as well, because now they know how much to do whatever they're going to do.
And it's been a long time, but for MAP we want to keep it around 70. Is that correct? Or
I think it's 65 to.
is it still?
Yeah, I was
between
going to say 60 to 65.
Okay.
Back to the big picture, though. We got real deep in the weeds real quick there. Use your capnography as a tool to assess how aggressive to be on your fluids. And whatever your decision, if you're giving fluids for protocol or for whatever, and the end tidal CO2 is going down, just know he's fixing to die. His only chance is to be opened up by a doc and a buttload of blood products given to him. Likewise, medics, you can make decisions about how aggressive to get on your dirty epi, or what are you guys doing for pressure drips?
Push dose or
epi.
Yeah, push dose epi. So you can make decisions about how to get, if you give your first push dose and nothing changes in capnography, it's still 20, I would double or triple the next one, even though you risk them going into VFib or VTAC. Make sense? Now do you kind of see the role of capnography and ACLS refreshers? If you're starting to make the connection of, yeah, it's rhythms, it's drugs, it's fluids, it's ventilation, but all of those things capnography is going to tell you before you're going to see anything that you are normally taught to do. Sepsis. I've done 2 sepsis alerts at Sandoval, and I used this protocol, and I waited to see what happened, and they rocked. Do you guys know Jennifer Stafford? She's their QI person, married to Brian Bird, retired firefighter. I called Jen after, I'm like, you guys understood what sepsis means in capnography? And she's like, I taught that shit, and they better understand it. So what's the standard for sepsis alerts? How do you guys do a sepsis alert per protocol? Or do you do them?
suspicion of infection, altered mentation.
Wait. How many things need to be present first?
2.
Okay, I'm gonna give you 3, but let's go.
Suspicion of infection.
That's 1.
Altered mentation.
2,
Fever. And then end tidal lower than.
wait, stop right here. That's a geriatric UTI, just so you know. That's every lady that's a UTI, so we need some more than that. But they're not wrong, keep going. Hypotension, tachycardia.
End tidal, I believe, less than 25. I
Or
think.
maybe hint, look at the fucking thing over there.
I could, yeah,
Less than 30.
less than 30.
So it's less than 30, and they want to duplicate 5 minutes apart. So we just named 6, and all 6 are great. I use 3 to trigger a sepsis alert, and I say over the radio what it is. Hey, this is 20 for 30, come in code 3 with a sepsis alert. I have altered mental status person with a blood pressure of 80, came out of the hospital or came out of the dentist 5 days ago, is also febrile, and my end-tidal CO2 is 26. Why does this matter for EMS to do sepsis alerts? What do we know about that? If you'll later look up sepsis bundle in first 60 minutes, nationwide, when a sepsis alert's called, it's like a STEMI, you have certain things that must happen in the first 5 or 10 minutes and things that must happen in the first 60 minutes to decrease mortality. And it's fluids, it's resuscitation, it's blood to the labs, and then antibiotics as quick as you can get them hung, which we don't do that. But if we can be part of the sepsis alert to get them into the right recess room to start that, we know that we can do that. On the East Coast, when they did sepsis alerts, they decreased sepsis mortality by 85%, because otherwise you just called it a UTI and they got sent out to the waiting room where they ended up having a bad outcome. So this is a cool place that we can make a difference. This is a big enough deal, and it was the consortium that fought it. Sorry, Darren. This is a big enough deal that for 4 years we've been trying to get lactate meters added to the New Mexico scope of practice. Other states do it, Texas does it. And it sucks that you can order them through Big 5, but we're not allowed to use them. The reason for that is they're not FDA approved yet to be used to make medical decisions. The lactate meters have been out forever. There are 2 meters out right now that do glucometry and lactate, but they're not FDA approved. And so UNM, being a medical teaching hospital, is like, we're not going to approve a non-medical application, which I get it, but other places use it. As soon as it gets approved, I'm sure every rig in the state will have lactate meters because they're out right now. Value of chest compressions. So if somebody's end-tidal CO2 was 11 with a good plateau, and somebody's sweating, and you say harder, deeper, faster, they go boom, 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 and it jumps to 18, what's it time to do?
Switch them out.
Yeah, rotate them out. So here's the study saying the same thing. If your end-tidal CO2 jumps up with a new rescuer, you waited too long to rotate. Scottsdale Fire added a second engine to their cardiac arrests, and the first officer on the engine at a cardiac arrest sat there with a stopwatch. And all he did is every 4 minutes rotated, forced her rotation, and he had an extra engine company to do it. They brought up the resuscitation rate 12%. That was like 10 years ago. Only department in this that I'm aware of that specifically did that because of staffing, but they're not as busy as you guys or an AFR, based on staffing resources. Mechanical compressions. Are you guys using any kind of mechanical compression device? Are you using the Lucas?
The Lucas.
So we know that every mechanical compression device works better than any of us. And the main reason is when you do that rotation, your cerebral perfusion pressure and your coronary perfusion pressure go to 0. And with mechanical, it can stay up. And so first off, it's a great new partner. And second, it absolutely works. Here's the prediction of the Ross that we talked about. So this is funny. So Seattle, King County, Marv Wayne, who's the medical director, argues that he's the best in the world. If you're a medic and you go to work for Seattle, King County, the first thing Dr. Wayne makes you do is take his paramedic class. Makes every single person be trained by him. He boasts that they have the highest cardiac arrest rate, survival rate in the United States, but he doesn't tell you that that only counts for VFib and VTAC on arrival. It only counts for witness CPR and pre-hospital AED activation if appropriate. So yeah, with that, in that scenario, I don't remember the number, it's like 50 or 60% in Seattle. And they do a ton of Project Heart Sharp kind of stuff to train the group. Nonetheless, he had 90 codes in the field. Of the 90 codes, he had 16 survivors. Of the 16 survivors, 13 had what we were talking about before. They got the Ross spike before they got a pulse or a blood pressure back. And again, he published this in 1995. Now, seizing patients. I'm going to do that. Oh, I'm going forward. Boy, I just jumped like 5 slides. What the hell? Oh, damn. I may have to reset everything here. Sorry guys, like seeing it, you're gonna be, I know what he's gonna say. Okay, here it was. So look at those 3 waveforms. Just look at the waveforms in the beginning. Then I'm gonna go back to it. So just look at the 3 waveforms. So earlier I said to the parapup, were you taught to intubate a seizure? And he said, really not. And he said he's never had to either. So the truth is, most patients who wiggle don't need to be intubated and don't need to be given drugs or ventilated. They do just fine, right? But some do. And those that do, what often happens is they're seizing, the medic gets a line, pushes the versed, and then realizes the patient isn't breathing, incorrectly assumes that he gave too much versed, maybe even gets blamed by his partners or his medical director for giving too much. And in fact, that patient was never breathing while they were seizing. The way that you know this, so if you have somebody who's seizing and not breathing, so they're seizing, and you're still going to attach to this. They're seizing, that's what you'll see. They're seizing, but they're ineffectively ventilating, you're going to see this. I would bag, well, for sure you're going to bag this guy while he's seizing. I'd consider bagging this guy. You see this is most of our seizures. This is the guy that you put a nasal cannula at 2 on, they quit seizing, they have the postictal period, they do just fine. Everybody gets this one right. Hopefully you get this one right. Almost everybody's gonna miss this until you put drugs on board and then realize that they're not moving. Make sense? Say yes? Okay, new call, real call. Okay, read the slide carefully. Notice the meds. Got it? And let's be real with this call. Okay, first off, just based on the first and second slide, sick, not sick?
Not sick.
Be real, not sick, right? She has cramping in her hands and her face is tingling. What's that called?
Anxiety.
But what's it called when that happens? Carpal pedal spasms, most commonly. So what's going on?
Attack,
Do it.
panic attack.
Panic attack, anxiety, what else? Simple hyperventilation, which causes the carpal pedal spasm, right? So hundreds and hundreds of times the slide has come up. Everybody says what you just said. Everybody. Now let's assume that, remember this call started as a domestic. Let's assume that the attacker is in police custody, because you never want to release somebody to go get beaten, hurt again at home or wherever they are. So let's assume the scumbag is in custody. Safe to let this patient sign a refusal?
No,
What'd you say?
no.
Why?
She, look under her history, she also has a history of asthma.
Really? How do you know that?
She's taken albuterol.
God, she's got a bunch of psych meds too, though. It's not an asthma call.
You won't know until we put her on cap.
When has asthma produced carpal pedal spasms? Ever?
Could you have it concurrently though?
Huh?
Could it be concurrently?
Ah, shit. You're actually the first person in a decade to say what you're saying. And you're nailing it. So everybody wants to let this person sign a refusal. Twice in my career, always on weekend nights when I'm tired and pissed off, I've let this person sign a refusal, and I've come back and they're dead. You hook her up to nasal cannula. Everybody got to see slide 1. He keyed in on albuterol and psych meds. Now, shark fin appearance? Yep. Let's make the number, just for giggles, 45. Now what's your treatment?
Asthma, airway constriction.
No, what's your treatment?
Oh, treatment. Dual neb?
Yeah, doing it. So you do a nebber, and you get this. Now, do you know with certainty that your treatment and his brain process were correct? Yeah. But listen to this. You gave a duo neb, and it's shit, I did it again. Ah. Why is it doing this?
Whoa.
Oh shit, they saw that. It's coming back. I may need to phone a friend here if you want to come up.
Yes, sir.
I don't know if you can do it from there or if I can do it from here.
Do you want to do a 5-minute break real quick?
Yeah, let's do 5. We're close, guys. Less than an hour. Yeah, go down. We're probably like slide 80, I guess.
Struggling?
Who's it, buddy?
It's a team effort.
Yeah, Brent. Perfect.
How's living with the wife?
You guys have to come back at 5 though.